Good morning, everyone. Today we'll do the neuropathology grand rounds with Dr. Kultekin today. So we'll just go through a few cases so we can start. So why don't we start with Long? Long, can you go ahead and read this case vignette?
Hey, Mr. Matt. Yeah, sure. Is a 20-year-old female, no significant past medical history, 2 weeks of headaches, presents to the ER for nausea, vomiting, and right eyelid droop.
Gotcha. So when you're thinking of something like that, what are you trying to think of?
So this makes me suspected for elevated intracranial pressure. Differential for that is, of course, broad, but I would like to start off with a stat CT head.
Gotcha. You obviously, when you're in the emergency room downstairs, you kind of get a little bit more stuff. You notice that the symptoms have been gradual. They're frontal, not associated with any photophobia, nuchal rigidity, questionable visual changes, but otherwise no symptoms. And this is her physical examination. Pretty okay, besides a small facial droop. And she has no papilledema. And so that's important because if we were to see optic nerve atrophy in one eye, discedema in the other, what syndrome could you think that this potentially could be?
Yeah, if I were, that would make me suspicious for Foster Kennedy syndrome.
Awesome. And what does that point you to?
Usually that's like a anterior skull base. I think anterior skull base meningioma.
Perfect. And so I know that anosmia is also one of the things that the classic triad presents with, but given obviously the imaging ability for us today, we don't necessarily find that as often because we can catch these things before. But exactly, the triad would be ipsilateral atrophy, contralateral papilledema in the eye, and then also anosmia. Good, very good. Fabia, if you're around, can you tell me what you're looking at, what you're seeing? Baby is not around, then Long, you can keep going.
Yeah, sorry. So there's a large right frontal mass, mixed density, maybe looks like hyperdense around the rim, hypodense interlesionally. There's also significant mass effect with around 11 millimeters of leftward midline chip. You can follow it up with an MRI with or without.
Perfect. And based off of kind of where it looks like it's arising from, would you think this is intraaxial, extraaxial? What are you thinking about when you see this?
Yeah, it looks like it's arising from the dura, and there's like white matter buckling surrounding the lesion, so I suspect extraaxial.
Excellent. And when you're looking at something like this, does it make sense with kind of what symptoms she's presenting with the headache, increased intracranial pressure, all that stuff? Makes sense, right?
Yes, yeah.
All right, keep going.
Okay. So I see that's a T2, T1 without contrast, and T1 with contrast axial. Looks like a heterogeneously enhancing right frontal dural base lesion. There's a pretty clear dural tail posteriorly. I would say differential for this would be meningioma, hemangioparasitoma, less likely dural based met.
Perfect. Doesn't mean the contrast enhancement looks kind of wispy, right? When you think of meningiomas, what are you thinking of when in terms of contrast enhancement?
Yeah, usually I think they're homogeneously contrast enhancing unless they have areas of necrosis or calcification within the lesion.
Perfect. And oftentimes some of these more aggressive meningiomas can have different contrast enhancement patterns, but you're exactly right. Homogeneous contrast enhancement is what we use to describe meningiomas most commonly. Right? And yeah, not very much edema in this.
Yeah, I don't see a significant amount of edema either.
So you already went through some of the differential diagnoses. There's a bunch of other stuff that theoretically, it could be right. And although we were looking at, you already mentioned the top three, I kind of bolded them right there. But you also have to consider things like, well, maybe this could actually be arising from the parenchyma underneath. It's just very large, so it's kind of the dural tail margin is kind of blurring. We'll get into kind of some of the pathology for this and the pathology report itself. But what would you do? She's young. She has a pretty big mass. What should we do with this?
Yeah, so she's young. She has these, intractable headaches. Also that I can't remember. I think her facial droop was on the left, correct?
It was on the right side. So,
oh, the right side. Okay.
Yeah, probably
so not
unrelated.
explained by the lesion. Yeah.
Her mom
I would.
brought her in.
Yeah. I would say, given also the kind of odd imaging characteristics, I would want at least, I'll probably operate right frontal craniotomy for resection, as well as for tissue for pathology.
That's exactly what happened. So this is a post-op. Congratulations, Long. You did a great job. So we can do some of the pathology slide review.
Good morning. This case is an oddball for sure. At this age group, with this high cortical location butting the meningeal surface or peel surface, I would have thought pleomorphic xanthoastrocytoma may be another differential diagnosis, a strong one, but the radiology is not super typical for it either. So this low power view shows you a considerably cellular tumor with some structures that are difficult to discern at low power, but they look like almost rosettish structures from a distance around blood vessels. Next slide, please. When you look at it on high power, you see a rather homogeneous size and shape in terms of the tumor cell nuclei, round, small, not really very atypical, and the structures are indeed some kind of perivascular rosetting or pseudo-rosetting. Next slide. So this high power shows that there aren't really many mitoses. In general, there was no true vascular proliferation or necrosis, and you can see that the tumor cells are sending their processes to the blood vessel wall, but not necessarily in a long tapering fashion, more like short stubby processes. This one is cut tangentially, so you have to use your imagination a little bit, but in areas where there's a nice nice angle at the bottom, you can see that the processes are short, and on GFAP we can see that they are not tapering, they are more short stubby processes, which is more characteristic of this tumor. Next. Yeah, you see here GFAP, glial fibrillary acidic protein, which is a marker for all glial tumors and ependymomas. And in this case, again, you can see this intensification of the reaction product, which is the dark chocolate brown. Notice that in between the reactivity is low, but around the blood vessels, you can see there's a narrow rim of reactivity, which consists of the processes of tumor cells. I mean, this could be seen in ependymoma, but again, in detail, there are some subtle aspects of this that support this other diagnosis. Next. C240 is another marker that we use for ependymal-like tumors, and it is variably positive here. Next. EMA shows punctate variably, punctate reactivity again, and essentially ependymal feature in that, instead of staining the whole cytoplasm or the membrane, it stains this Golgi-like pattern in a dot-like or punctate fashion. Is there another slide? Yeah, so the diagnosis read by Dr. Saad was astroblastoma. Astroblastomas do have some ependymal differentiation, and I'm sure you're going to talk about it. The most classic versions are more, they exhibit or display more sclerosed blood vessels. That is more typical, and they have different molecular subtypes. That's all I have to say from the neuropath point of view.
Dr. Gottlogen? Yeah, so the astroblastoma is definitely a diagnosis that I don't think anyone was expecting. I discussed this case actually with Dr. Bhatia, who read the initial MRI, and similarly, she was intrigued to find that it was astroblastoma. And so what is this? It characterizes a circumscribed astrocytic glioma in the current WHO classification of CNS tumors. It doesn't have a grade quite yet. And so part of the importance of pathology is how to guide adjuvant therapy, ranging from indolent, low aggressive astroblastomas to anaplastic. The thing that's most important for us to know is that there's an alteration in a transcription cofactor MN1. It's involved in meningioma formation, actually, in AML. Now, obviously, she's a 20-year-old woman, so interestingly, she kind of hits exactly this: a female predilection and age mean between 10 and 30 years. So the treatments for these generally include something that's simple. Part of the process with this lady in specific is that her features were just on the cusp of aggressive, meaning that the cutoff is usually greater than 5 abnormal mitoses per high-powered field, whereas hers was 4. You had palisading necrosis and aggressive. Hers is kind of mildly necrotic. And so part of the discussion for her from the radiation oncology standpoint was to watch before radiating. So she's not undergoing radiation. I think the CNS tumor board is going to discuss her case to kind of figure out what the next steps for her are going to be.
Does she have NGS results yet?
I didn't see that in her chart when I checked like maybe a few days ago, so I wasn't aware of that.
Yeah, so just know that again, these can display 3 or 4 different molecular subtypes. One of them is the MN1 alteration. That's the low-grade one. Some of them look like a PXA, and others look like GBM. So the morphology alone isn't necessarily 100% predictive of the course, but another important thing is that this was not related to the ependymal surfaces, right? That's important. And relatively well circumscribed, and in non-eloquent locations, it may be more eligible for a gross total resection. Those are important factors in general. Young age. So these are all good things for a better or more favorable prognosis, correct? But the molecular subtype would have been interesting to know. I just didn't have a chance yesterday. I learned I was going to present this case, but maybe if it's a recent case, then we have to wait for probably a month or so to get back the molecular results. Thank you.
The next case, we'll go with Seth. Are you on?
Yeah, I'm here.
Perfect. Go ahead and read and tell us your thoughts.
All right. We have a 72-year-old female with sudden onset but transient left hemibody paresthesias.
Not very much you're going to glean from that. Oftentimes they won't even call us for something like this. I'll call it neurology or something for a stroke workup. But in the process, just so you can see, no preceding prodrome, no evidence of seizures or gustatory sensation, self-limiting. And otherwise, after these paresthesias, she was completely intact. And so they get an MRI, or sorry, a CT scan, part of the ED workup, and they see this. So what do you see?
Yeah, so on the right, it looks like there's a isodense lesion um, and the right insular area.
Nice. Yeah, very, very subtle, right? Like you have to really kind of zoom in. If you didn't get it, I was gonna have to point it out to you, but you got it, so we're good.
So I want to get a MRI with and without.
Perfect. So you get that MRI with and without, and this is FLAIR and T2 weighted imaging. So what are you seeing there?
Yeah, on the flare we see a lesion with edema around there on the left, and then the T2 it looks, yeah, again like this lesion in the insula with some heterogeneous components.
Mhm, mhm. So oftentimes when you see something like this, right, insular lesion, clear circumscribed, edema, when you contrast enhance it, what do you think would happen?
I think it would be contrast enhancing.
Yeah. And so it was partially contrasted.
Hmm.
And so look, if you look at this scan, you can see the T1, then the T1 with. This partial contrast enhancement is interesting, though, clearly circumscribed lesion. You have a contrast enhancing lesion. So symptoms are paresthesias that have self-limited, but in the process of kind of working this up, what are you thinking about for this case? What are you thinking about the diagnosis differential could be?
Yeah, I think our differential would include some kind of glioma, high or low grade, possibly Mets. I'd want to ask about any kind of cancer history. Maybe an oligodendroglioma.
The CT itself didn't necessarily show any calcifications, but you're right, they don't necessarily need to always be present. And this is just kind of a little question for you. If you can see my arrow, what is this structure here?
The putamen.
Perfect, perfect, perfect. And that becomes important because obviously if the next step is going to be to do something about it, right, you need to know your limitations for how deep you can be. Perfect. So you already kind of going over the nice differential. And then what do you want to do for it?
I think given that it's sort of close to the surface there on the right, we could do a right cranie to for resection.
And Tyler, if you're on, I have a question for you. I'm bump it up a little bit. That is okay. All right. Well, the question would be, obviously when in line to getting to the insula, what kind of structure do you have to go through, dissect carefully? What zone? All this stuff here. Seth.
Like you have to part the fissure.
Perfect. So Sylvian fissure. So a lot of this is going to be then the temporal crane or the terminal craniotomy is going to be centered around the Sylvian fissure here, and you're going to have to split to get to the insula. Then good job, Seth. You did a great job resecting. So then we have the pathology review for this.
Yeah, so this high power view shows a couple of mitoses in the center right, and you can see that overall this is a very pleomorphic, highly cellular tumor with large nuclei. Again, a couple of mitoses. So from the get-go, it looks like a malignant glial tumor. Next. Please. Yeah, so this one shows a lower power, same thing, highly cellular atypia, nuclear atypia, not so much vascular changes in this field. Next. Here is some necrosis, kind of a palisading necrosis that completes the criteria for a glioblastoma. There are no clear cell features, so I wouldn't think it would be an oligodendroglioma at this point. Next, TFAP is strongly positive. That also supports the astrocytic phenotype. Next. So it's also IDH1 wild. How old was the patient? Sumer?
She was 72.
Okay, so the patient is about 55. That means the IDH1 point mutation that we are looking at with immunohistochemistry will be sufficient to call this an IDH wild type glial tumor. So glioblastoma, IDH wild type, WHO grade 4.
And so, obviously we know a fair amount of glioblastoma, STU protocol, etc. But something important to kind of keep in mind, something that we get asked quite frequently during morning conference, and Seth and Vedya, this is kind of for you guys too. The prognostic indicators for low-grade glioma survival. And so oftentimes you'll be asked what are the cardinal features that would predict something from low-grade becoming malignant or a more aggressive low-grade lesion, right? This was a case in which the contrast enhancement kind of pushed you towards thinking this could be of higher grade. Low-grade gliomas don't oftentimes contrast enhance as avidly, and if they do, it's a little bit aggressive. And this is a good paper, essentially from the European Organization for Research and Treatment of Cancer, that essentially looked at a fair amount of patients and did an analysis on which patients had higher likelihood of low survival at low grades. And so things like age, so age greater than 40 years, the histology subtype of astrocytoma, obviously large tumors that cross the midline, and any presence of neurological deficit before surgery were prognostic factors for survival. So that's going to be important, obviously, for you guys when you're seeing these patients, particularly to guide therapy. If this is something more aggressive, this is something less aggressive, something to keep in mind. So she, unfortunately, even if this were a low grade, 40 years, astrocytoma history, and then the presence of neurological deficit, any three of those, two to three of these factors, I think are prognostic for poor survival. Is Turkey available?
Yeah, I'm here.
Turkey, can you please read this?
Yeah, 22-year-old male presenting to the ED with a month of right-sided headache associated with subjective decreased visual acuity, exacerbated over last 3 months.
Here on call, and you got all these right-sided tumors. So this is headaches are constant, worse in the morning, associated with nausea and vomiting at times. The visual symptoms progressively worsened, no history of trauma to the head or the orbit. And can you kind of read in the bold what the physical exam findings are concerning for?
Yeah, so it seems that he's narrow intact, except that he has mild left-sided visual neglect and homonymous hemianopsia.
Right. So this is the CT scan that was done in 2020 on the left. The scan on the right is the one that you have in the emergency room. So when you're comparing these things, what's striking you?
So in the new CT, there is a right temporo-occipital. Also, it makes sense to the parietal lobe. Hyperdensity with associated vasogenic edema that could represent a mass lesion.
Perfect. Kind of with that edema that's there, does it make sense with why he may be having visual symptoms as well, not just signs of increasing intracranial pressure?
Yeah, because of the because it's adjacent to the occipital lobe, it's almost invading the occipital lobe with the vasogenic edema, so I'd expect symptoms there.
Perfect.
Plus the neglect and the parietal lobe.
Exactly. What would you want to tell the emergency room that what are the next few things you should order for this patient? Despite him being 22, what are the few things you should ask for?
So I would get an MRI of the brain with an CAD. and also he's too young for metastatic disease. So, but I would still do CT chest, abdomen, pelvis, make sure that there's no extra CNS metastatic disease. That's
What you know, he's young, right? So the likelihood of metastatic disease is low, but where is a location where he could theoretically have something come from in a young male?
testes. I would do testicular ultrasound.
Perfect, which is negative. So excellent. And then the final blood work that you would get for, apart from the obvious preoperative stuff, what is something that you could ask for in the emergency room? A young gentleman, a weird layout.
To make sure that it's not a germinoma, for example. We just make sure that we do the fetal protein, beta HCG.
Yeah, definitely can be done, right? Those are like more likely would be for pineal region masses, as you know, but nothing would be HIV test, something simple in the emergency room. This is a very weird, aggressive lesion that appeared over the last course of 3 years. So unfortunately, thinking this could be malignant, but he's young, so we'll see what the scans are showing. So this is the with and without.
Yeah. So there's no hyperintensity on the plain MRI, but it's enhancing on the MRI with GAD. It seems that it's homogeneously enhancing with irregular shape. It's cortical, also extends the subcortical layer. Mass effect with some mild midline shift, but it's in the temporoparietal and also extends to the occipital lobe.
These are the T2 and flares, so a significant amount of edema.
Yeah, also extends to the splenium of the corpus callosum.
Perfect. So when you're looking at something like this, right, very atypical looking lesion, young gentleman, what are you thinking about?
Given his age, it could be a glioma, a primary CNS tumor. It also can be, primary CNS, meaning it can be low grade, high grade, and also less likely metastatic disease, but it is within differential. It doesn't seem to be an abscess. Would like to see a diffusion, but doesn't look like an abscess to me. It also can be a lymphoma. If we do, for example, HIV testing is HIV positive, it can be a CNS lymphoma.
Very good. Yeah. So, high-grade glioma, lymphoma, metastatic diseases. Don't forget, some, young gentlemen, some of these tumor factor demyelinating diseases can look very, very atypical, very weird. Now, again, this probably isn't going to be the highest part of your differential, but something to keep in mind, right? Abscesses, like you mentioned, unlikely given how non-toxic he appears when you see him, but something to consider, right? The flare, if it was very intensely diffusion restricting, a very clear ring enhancement. These are kind of things you could think of. And then toxoplasmosis, right? Like unlikely, CT scan didn't show any significant calcifications, but possible. There's not keeping on your differentials aren't a bad thing. But that ultimately doesn't significantly change what we need to do, which is what?
Sorry, I didn't hear the last question.
Yeah, what do you think? This patient has negative CT, chest, abdomen, pelvis, negative scrotal ultrasound. He has this mass lesion that's there. What is the next option for this gentleman?
Yeah, so he needs a biopsy, at least to make sure what we're dealing with. And also, that's the first goal. And the second goal is to decompress. He has a large vasogenic edema and it's causing mass effect. So that needs to be decompressed, meaning that we need to resect that lesion. If it's depending on the pathology, of course, but so we need to do a pathology, histology and biopsy first.
Absolutely. So you do a right temporal craniotomy. The plan for this patient was to try to resect as much of it as possible, but did you send frozen during this case?
Yeah, would do that.
Perfect.
And I would not start him on Decadron before the case, just to make sure if it turns out to be a lymphoma, it wouldn't mask diagnosis.
Yeah, exactly. And oftentimes you'll see these lesions, particularly in the emergency room for some of the juniors, right? You'll see these very well circumscribed lesions, or these lesions on CT or MR that are clearly a diagnosis, GBM, meningioma, something like that. And so for those ones, right, that you're kind of your gestalt in order to start people on steroids. When you have these very atypical lesions, right, it's not sometimes a bad idea to wait, discuss this potentially with this chief or attending about whether or not you want to start Decadron, because you're exactly right. Right, if this were a lymphoma, you start a Decadron, then you can mar the results of your biopsy. So in the case itself, the plan was for resection, like you mentioned, Turkey, and part of the process is the majority of the tumor bulking was done, and the frozen had come back, and then obviously there's a little bit of rim that was left. So that is a clue in for what the pathology may show.
If the frozen comes back as definitive lymphoma, what would you do in terms of the intraoperative decision making?
Yeah, it's a phenomenal question. I think part of if the lymphoma and what actually had occurred was was exactly that. Part of the decision when the pathology did come back was for lymphoma. I think part of my gestalt and part of my decision making would be, this is a potentially very very sensitive cancer, and so stopping before getting into areas. But this is a right parietal lesion. He has some visual deficits, and I think we have adjuvants for this gentleman that are very beneficial. I think that just simply doing a biopsy to get that would have been acceptable, but this was such a large mass, right? I think that the goal would have been for complete debulking. And once you have a pathology, you've debulked a fair amount. There was obviously a fair amount of pressure on that scan. Once you've debulked a fair amount of that tissue, you have pathology report suggesting something that you may stop with. I would have stopped exactly as what happened. A fair amount of the tumor was resected as well, which is a good thing. We're going to talk about actually some new data that's coming out about resecting, or like extent of resection for these types of lesions. But I would have stopped.
Okay. Yeah, so I thought previously that resecting lymphomas, if it's a lymphoma, was not necessarily the course of action. But I think in the last 5 years or something came from some publication came out of Germany that said that the lymphomas, actually the resected ones, may actually do better even, and that was kind of an isolated publication, and I'm not sure if the practice has changed or modified. I understand the decompression part, I understand cytoreduction, but we stress over some of these frozens not to miss lymphoma, thinking that it's going to make a difference in your surgical planning. I just wondered how, if there's a standard of procedure for these things. Anyway, so you can see that this smear intraoperative touch prep shows round naked nuclei with not much cytoplasm, as you can see, and typical chromatin pattern for lymphoid cells. Next. And here you see a very cellular lesion. Same thing with more prominent nuclei and not much cytoplasm. And there are a lot of apoptotic bodies. CNS lymphomas also show a perivascular angiocentric pattern, which is not very obvious here. Next. But this is definitive. CD20 marker of B cells is strongly and definitively positive in every single cell except the blood vessel walls. So this is a large B cell lymphoma. Ki-67 typically is very high, above 50%. Actually, in general, it reaches 90% in most high-grade lymphomas. MOM1 is a marker of differentiation in the B cell lineage, and it shows that this is a non-germinal cell, a non-germinal center cell lymphoma. This is something done by hematopathologists and for characterization of all lymphomas. So this also supports the diagnosis. So diffuse large B cell lymphoma.
Dr. Golpekin actually referred to the exact paper that I wanted to show you guys, because he's exactly right. You know, prior the idea was that when you have CNS lymphoma, that the extent of resection does not matter, right? And so there's a group that came out of Germany, and part of this clinical trial in Europe that looked at whole brain radiation as an adjuvant therapy for CNS lymphoma on top of what is already being done. And when they did a subgroup analysis as to the extent of resection, what they found is that patients with complete or even partial resections actually had better overall survival, as well as progression-free survival when compared to biopsy alone. Now, granted, this time frame, you know, a lot of these results are primarily within that 36 to 60 month range, particularly when you see the drop off. But you know, it's an interesting, thought-provoking idea that essentially we should be more aggressive with resecting lymphomas. But I don't necessarily think that this is going to be defining literature quite yet. But just something to keep in mind that although the teachings are that lymphoma resections are not necessary, there are some data to support that long-term survival is improved when you resect the whole thing, even partially, as opposed to just doing a simple biopsy. So that's something to look forward, keep in mind that the data seems to be now penduluming the other way.
I mean, this is a 2012 paper. Is there anything in the last 10 years that's been published on this? Because, you know, like if you look at the patients who have been treated with chemoradiation alone, it looks like the tumor is not even there. You know,
Yeah.
We just went over some oral boards yesterday and showed the case. So I'm just curious if there's any new data that says this paper doesn't look like it's really. And if you look at the survival curves, they're not that impressive either.
They're not that impressive. And I think, yeah, it's a good question. I didn't see anything more recently. What I'm thinking though is that exactly you're right. You know, the at 3 years, fine, you can say that there's some improvement, like 10, 15%, 20% max of patients, not even, that are improved. You can see in the overall survival at 36 months here. Maybe with complete resection at the 4-year mark is the highest, but even then, the curves aren't super impressive. I think this was primarily more just to keep in mind, thought-provokingly. I don't think that this is going to change our management per se, or else something more substantial is going to have to come out in order to make us be more aggressive with these resections. I mean, we don't even give steroids for these patients just because it reduces the yield of biopsy. So I don't necessarily think that this is going to change our management of these. You're right that in the last 10 so years, this hasn't been a fruitful endeavor in terms of research. But you know, the European colleagues seem to have thought that in the sub-analysis of this group, there was some survival benefit. So I think that for us, we probably won't be changing much unless it becomes more definitive. I have no real good literature in the last 3-4 years that would indicate that we're changing our pattern. So the next case, why don't we go with Aman? Are you available?
Yeah, I'm here.
Perfect. Can you go ahead and read this for me, please?
Yeah, so this is a 62-year-old female, primary low back pain. Comes in because of feeling a lump on her back.
Yeah, seemingly very rather benign, right? Back pain, palpable mass. She states that she has had this mass for a very long time. And when she was like 12, she kind of noted, you know, she's an older lady, 62, but she can remember that when she was 12, she always felt like her back was extra sensitive. She was involved in a car accident in 2023, like earlier this year. And since then, her back has just been killing her. But she has felt that mass for a very long time. No cancer history, no surgical history. She's neurologically otherwise grossly intact. And so long-standing paraspinal mass, What are you thinking? Why are we even why is she coming to us, etc.?
Right. Why is she coming to us? From the neuro end, schwannoma, neurofibroma jumps to mind. But it could also be, not neurosurgery. It could be something like a lipoma or sarcoma, some connective tissue, anything like that. I think is all in my differential right now.
Yeah. So you're thinking like, well, this could, there's a whole broad range of things that this could be. And she's coming to you, she's in clinic, she's coming to you with this MRI. And so you have a T2, T1, and T1 with contrast. And so what are you seeing here? What is it showing you?
So we see the T1, we see the hyper intense lesion. It's we said it's paraspinal, but looks, it could be paraspinal or midline. I guess I can't really scroll through it. And sorry, what was that on the right? Which sequence?
On the right, you have T2, T1, and T1 with contrast. So this
okay. So it is enhancing, on the contrast scan as well. So I'm not expecting that from something like a lipoma. Right now, it's going to be picking up contrast. Yeah.
Because a lipoma would be bright on which one of these?
Lipoma would be bright on a T1.
Very good. So it's not very bright on T1. We're not necessarily, lipoma drops on our differential. This is a potentially soft tissue mass. She's feeling it. This is something where she's she's concerned about it. She wants it out. She wants it biopsied, or at least biopsied or whatever. When you're looking at this, right? What are the things you're thinking about when you're considering removing this and counseling her for removal?
Every time first is removal versus biopsy. I would counsel her on, one, if we think this is like a neurofibroma or schwannoma, we'd want to know maybe some sort of cancer history if it's any family history if it's like a neurofibroma. But there's always a chance that there's this is malignant, and that's going to sort of change, I guess, surgical planning as well, and change what we're going to do as far as a biopsy or not.
Yeah. And exactly, this has been there for quite a while, and so part of the discussion for this case is, well, if it has been there for a while, could it be possibly malignant? Well, absolutely could be, right? But less likely given the fact that of its history, no other history of cancer, etc. You've gone over the differential very well, so neurofibroma schwannomas are rare in this lesion, right? These are nerve sheath tumors, right? And so part of then that process is going to be, well, the nervous tissue in this area, could it be rising from one of those smaller vessels or smaller nerves? Very light, and possibly soft tissue sarcomas, more aggressive rhabdomyosarcomas. These are the ones that are super aggressive. You need to be very aggressive on your treatment for. Lymphoma, lipoma. Lymphoma can do anything, so I just put it out for everything. But in primary bony tumors, again, it's unlikely, right? If you were to look at the axial, I apologize for not having an axial cut. You can see that it's a little bit eccentric to the left, near and kind of adjacent to, if not even touching the spinous process of I think it was like L3. And so part of then the question for you is going to be, what are you going to do about it? She wants it out. She's had it for a while. She's starting to have significant back pain. She really, it's a very large lesion. It's a fairly large lesion. And then finally, are you going to take it out in one piece? Are you going to piecemeal it? Are you going to biopsy it only? What do you think should be done? And if we can bump this up too, or you can take a crack at it, whatever you prefer. Ahmad, are you available?
Oh, I think he's in the OR.
Okay. So go for it, Ahmad.
So our options of take it out, biopsy versus take it out sort of piecemeal, or take it out like en bloc, like a resection. I think that would kind of depend on what our clinical suspicions are. But if we think this is malignant, then I would probably, especially location, just go do like an en bloc resection, and take the whole thing out.
Perfect. Yeah, Yeah, and so well, the idea behind this, right, is that you want to get a fair amount of resection for this, right? Because if it is something where it's very aggressive, you don't necessarily know, right? Placing a needle down it could be an option, but you can always seed that tract, right, with a needle biopsy. If you subtotally resect this thing, then you've done very, very little. If not, then add a compartment for this thing to move or metastasize. And if you don't take adjacent tissue, then you may not be getting some of that reactive kind of component of these masses that can go expand beyond the capsule, pseudocapsule of these masses. So the plan was to actually be a little bit slightly more aggressive, partial laminectomies of L2 to 4 to get that whole block, and then the mass removal of the lesion, potentially a little bit of muscle around it, trying to spare as much of that as possible, but trying to take this out in one piece. So we can do the pathology review.
Yes, go ahead. So this looks like a spindle cell lesion, like a streaming fascicles of spindle cells. There aren't many mitotic figures or any necrosis. Next. So here you see the biphasic nature of this tumor. The famous Anthony A and Anthony B type areas are shown here. The top is Anthony A, the bottom is Anthony B, the looser area. So that's a characteristic of schwannoma. Next. And you can see some secondary characteristics of schwannoma. For instance, at the top, you can see histiocytic infiltrates, and overall, you can see blood vessel walls that are hyalinized. These are signs of a long-standing, typically seen in long-standing benign tumors, such as schwannoma. Blood vessel wall hyalinization, inflammatory infiltrates, histiocytes, etc. Next. And this Soxtan is a definitive marker for this. In this situation, of course, Soxtan can be seen in other tumors, such as melanoma, but this is not a melanoma. This has all the features of a schwannoma. You can even see Verroque bodies with this stain. Anyhow, the diagnosis is schwannoma, WHO grade 1. It was like a 6-7 centimeter in greatest dimension. It was a big lesion, as you saw in the MRI.
Part of the interesting part about this case is that you would think that schwannomas would be more closer to larger nerve roots in the area. I believe the attending surgeon, Dr. Levy, in this case had never seen a schwannoma in this location this large. So it's a very interesting case. But she did great. She's happy. She's about to come to clinic soon. And this is an orthopedic surgeon who did a lot of soft tissue and sarcoma lesions, Dr. Enikin, who was at University of Florida, kind of described this classification for resection for local procedures. And we while we're not obviously operating on femurs or thigh muscles, the concept still remains of good oncologic practice, right? To debulk the tumor, cytoreduction within, to get the margin of the tumor, to resect a wide array of the tissue around it, or to completely remove the entire compartment that the tumor sits in, right? And so we would classify probably this one as a wide resection, given that we remove some of the lamina of the adjacent bone, some of the muscle tissue around. But just to keep in mind, good oncologic practice, right? You don't want to get it to something that you don't know necessarily what it is and seed it elsewhere. So being more cautious and conscientious is more important. I think that we have 9 minutes, so this one's pretty straightforward. I can just read this one. 80-year-old male, history of infratemporal malignant mass, presenting with progressive gait instability and lower extremity weakness. Vaidya, are you on?
Yeah, hi.
Perfect. Hey, Vaidya. I'm sorry, I wanted to get you, Aman, and Seth a good chance to hear voices today. So when you're seeing something like this, right, gait instability, history of cancer, had surgery for a sphenoid wing meningioma in the 90s. Gait
Mhm.
instability is associated with feelings of lower extremity weakness, and the patient on exam feels diffusely weak in the lower extremities, unsteady gait, and has a subtle sensory level in the upper thorax. Where is this? Where what are you thinking when you see all this? Put it together. You have one image test. You can order one imaging. What would you order?
Would get an MRI of the T-spine.
X. And that sensory level is going to be important, right? For that, obviously, like upper thorax, you're thinking of a lesion in the thorax itself, potentially near the spinal cord, given the subtle signs of myelopathy with that gait instability. This is just to show you if you had said MRI of the L spine, I would have said, well, here is this, right? What are you going to do for this lesion? But you're not going to do anything that doesn't really describe or explain the symptoms of what this person's having. So what do you see here?
Let's see. Sorry, it's loading. Oh, okay. Yeah, there we go. So looks like he has an
Sorry, baby. I think the audio cut out. Well, good job, Avia. You did exactly. You got the T-spine one. Seth, if you're on, or Aman, we have 7 minutes, so quickly. What do you see here? Seth, what do you see here?
sorry, I my
Oh, Veda?
oh, do you want me to do it or?
Yeah, Veda. Yeah, sorry.
Okay, yeah, sorry. See an intradural extramedullary lesion. And I can't really tell the vertebral level it might be at. Maybe T4. I'm not entirely sure.
Well, that's totally fine. Really quickly, the way I like to look at this is that if this is a thoracic MRI, the first vertebrae, complete first vertebrae you see has to be T1 or is likely T1. So 1, 2, 3. So T3, T4 region is exactly where it is, and you're exactly right. Extradural, intramedullary lesion, or sorry, intradural extramedullary lesion. You can see that the spinal cord is being abutted and pushed ventrally here. Very good. And it's not expanding the spinal cord, right? So you can see the dura behind it. You can see a nice, the hypo intensity of the CSF. It's not being the whole space is not being compressed, just that the spinal cord is being. So yeah, exactly right. This is just another view of it, exactly telling you what you already told me, which is that it is an intradural extramedullary lesion. And right, you can see the spinal cord is being pushed ventrally. You have CSF spaces above and below that are not being indented. So this is likely not extradural, and it's not expanding the cord. So it's not intramedullary. So process of elimination. So this is, we have a little bit of time left. So really quickly, this is critical for you guys to know, right? There are lots of things that these things could be, but there are very, very specific things that are most likely for it to be. So Vaidya, tell me, intradural, intramedullary, 2 things. Go.
Intradural extramedullary, maybe a schwannoma or.
Oh, sorry, intradural, intramedullary.
Oh, intradural. Oh, sorry, intramedullary. Could be like a MET potentially.
It could be a MET, yeah. When you're thinking of let's say, when you're thinking of spinal cord lesions, 2 things are more common. So MET is one of them. It's on the list, but I put that as like 3 or 4. Oh.
Maybe would a syrinx count?
Not necessarily like a tumor per se. I mean, it could be related, right, to something that leads in that area. But what about the spinal cord is made out of neural tissue, and neura need glial cells to support them, and glial cells we know can do what?
Like a spinal glioma of some kind?
Yeah, spinal, like astrocytomas is one, and then let's say the lining of the lining of the central canal itself, where the CSF goes within the spinal cord, is what's around that. It's the quote lining.
Ependymal tissues, or maybe like an ependymoma.
Perfect. So I know we're kind of running out of time, so I'll just kind of do this. But this is incredibly important for you to know, right? So this is something where I very quickly can delineate what your differential is going to be and what you're going to do for it. So astrocytoma and ependymomas for intramedullary IDIM, IDIM tumors, intramedullary, intradural. Hemangioblastoma, less likely but possible, METs. Intradural extramedullary, meningioma, neurofibroma, schwannomas. You can have leptomeningeal METs and myxopapillary ependymomas with a star. Ependymomas are intramedullary, right? But in the conus / in the cauda equina region, the myxopapillary ependymomas or lesions that you'd find there are extramedullary. So that's one of the ependymoma classifications that would be extramedullary. And then finally, extradural will be bone tumors, METs to the bone, like prostate cancers, lymphomas, plasmacytomas, etc. So operative plan, you did a laminectomy for resection of the tumor, and this is the pathology review.
It's a low-grade spindle cell lesion. The cellularity is low. Cells nuclei are elongated. The background is fibrillary. Next. You can see what I said under high power here. Multicellular lesion, dense fibrillary background. Next. And you can see beautiful examples of Berroquet bodies where there is true palisading of schwannoma cells around a non-necrotic anuclear center. Next. And SOX10 supports the origin of Schwann cell. So this is a schwannoma straightforward case.
The important part about this that I wanted to go over and discuss is obviously again, this is going to be inundated. It's going to be drilled into your head, but the differential based off of the compartments when a spinal lesion is seen, right? Intradural, intramedullary, intradural, extramedullary, and extradural. They have very few things they could possibly be. Obviously, there's red herrings and zebras everywhere, but if you have a very fast, quick way of determining, is this intradural, is this intramedullary or extramedullary, or is this extradural, then you can basically delineate what you think it is, what the plan should be, etc. So with that, we have 2 minutes of a little break time between the talks for the sub-I talk. So good job, guys. Thank you very much.
Thank you so much.
Thank you, Dr. Kotekin.
All right. Hello, everyone. My name is Payman, or PJ Rezai, from Tulane University. And I'd just like to start by just thanking all of you for allowing me to be here and for taking the time to teach me. I'm really impressed with this program and feel like it's an honor to be here. So today I'll be presenting some work involving machine learning, which is a passion of mine, titled Identification of Factors Associated with 30-Day Readmission After Posterior Lumbar Using Machine Learning in Traditional Models. And this is a national longitudinal database study. So spinal fusion is currently the 6th most common surgical procedure in the United States, with over 400,000 cases and over $10 billion in aggregate hospital costs annually. Unfortunately, the 30-day readmission rate can range between 2 and depending on the peer review article. So increased focus is being placed on developing predictive models that identify patients at high risk of readmission, subsequently applying interventions to reduce their readmission risk, and in turn, improving health outcomes and reducing healthcare utilization. Of note, we can use these models not only to predict readmission, but also to determine factors most associated with readmission to help guide the development of specific interventions. Now, these models to predict readmission can be stratified into 2 groups: traditional statistical models and machine learning models. And prior to 2008, traditional statistical models such as logistic regression were widely used for identifying factors associated with readmission, as well as for predicting readmission. Recently, however, there's been a surge in machine learning techniques to predict readmission, many with improved predictive performance over traditional techniques. However, none so far have leveraged these machine learning models to identify factors most relevant for predicting readmission in the setting of posterior lumbar fusion. And as you're already aware, factor identification is crucial for developing interventions to reduce unplanned readmission. So this study aimed to identify risk factors associated with unplanned 30-day readmission after posterior lumbar fusion and instrumentation using both logistic regression and machine learning models. Furthermore, this study sought to assess the predictive performance of these models on readmission, compare their predictive performance to that of the validated LACE index, and estimate the potential cost savings of implementing these models in clinical practice. And just as a note, the LACE index is a clinically validated tool that is currently used nationwide. It uses 4 factors to predict the risk of readmission, and these include length of stay, acuity of admission, comorbidities, and emergency visits. So we use the Optum ClinFormatics database in this study, which includes over 80 million unique patients nationwide. Data was queried from 2004 to 2017, and patients were identified based on CPT codes for lumbar laminectomy, posterior fusion, and instrumentation. Patients were excluded if they had any concurrent procedures listed on the screen, if they had less than 7 months of continuous enrollment, and if they did not have a complete set of data. In other words, a value for each variable of interest. A total of 76 variables were used in the study to develop our models, and these included demographic factors, socioeconomic factors, procedural factors, utilization, specific comorbidities, and specific complications. So next, 4 machine learning models and a multivariable logistic regression model were then generated. These models included gradient boosting machine, or GBM, XGBoost, random forest, and lasso. The machine learning models were then compared to one another based on predictive performance, which was determined by area under the receiver operating curve, or AUC. The top performing model, which happened to be GBM, was then used to identify factors associated with 30-day readmission. These factors were then compared to those most associated with readmission using logistic regression. GBM was also compared to logistic regression in terms of predictive performance. And finally, GBM was compared to the LACE index in terms of predicting readmission, as well as the potential cost savings associated with implementing these models in a theoretical clinical scenario. All right, so a total of 18,981 patients were included in this study, of which 16.2% were readmitted within 30 days of initial admission. Discharge status, number of prior admissions, and geographic division were most influential for the logistic regression model, while discharge status, length of stay, and number of prior admissions had greatest relevance for the GBM model. We found that GBM also significantly outperformed logistic regression in predicting unplanned 30-day readmission, with a mean AUC of 0.865 versus 0.850. Finally, GBM was also compared to the LACE index model in terms of predictive ability and potential cost savings in annual terms. For the 20% highest risk patients in our cohort, which turned out to be 291 patients, the true positive rate was 95% for GBM, whereas it was only 53% for the LACE index. And after applying our theoretical intervention, which reduced readmissions by 50%, the GBM model saved $2.2 million in readmission associated costs annually compared to the LACE index's $1.2 million annually, which represents an 80% increase in cost savings by using the GBM model. And if we were to extrapolate this finding to all patients nationwide, the cost savings achieved by our GBM model could potentially reach tens to hundreds of millions of dollars annually. Okay, so here's some key findings. First, factors associated with readmission vary based on which predictive models are used. For example, length of stay had an order of magnitude greater relative importance for our GBM model than it did for our multivariable logistic regression model. Therefore, it may be wise to use results from multiple models when determining which factors you want to target when you're developing interventions to reduce readmission. Second, this study's GBM model achieved a mean AUC value of 0.87, which is to date the greatest of those achieved by all previously reported machine learning models designed to predict readmission following lumbar surgery. And this could be partially explained by the choice of variables used in the study. For instance, we found that transfer to skilled nursing facility had the greatest relative importance for our models, but only one other study had used this variable in their model, and they ended up with the highest AUC prior to our work. Interestingly, they only used 14 variables in their study, had they used our combination of variables, their AUC value may have reached or surpassed ours of 0.87. Finally, our GBM model outperformed the LACE index in predicting readmission and reducing potential costs associated with readmission. This finding suggests that machine learning models have the potential to supplant current clinically employed predictive models for readmission as soon as today, which can potentially save hospital systems millions of dollars annually. In terms of future directions, we're currently assessing the generalizability of our GBM machine learning model using institutional data from Stanford Medical Center and the Mayo Clinic. We'd also like to eventually develop and test interventions and protocols to reduce readmissions based on the factors we've identified as most important for predicting readmission. And finally, I'd just like to thank Doctors Desai, Ratliff, Herrick, Shanker, and Rusu at Stanford University for their help with this project. It wouldn't have been possible without each of them. Thank you.
Very nice. Thank you. I think we're going to have to hold questions so that everybody can get their talks in. Please approach them later with questions. Next is Natasha.
Beautiful. Thank you so much. Hi, everyone. My name is Natasha. I'm one of the sub-Is here, for anyone who doesn't know me. So basically, as you can see, I'm fond of film, and so I wanted to combine my love for cinema and my love for neurosurgery into this project. Okay, next. Okay, so a little bit of background introduction. There's long been a relationship between art and medicine. Specifically, the visual arts provides a unique perspective on humanism in medicine because it provides a platform for reflection, interpretation, and dialogue of the illness experience. And so one of the main goals of this project was to contribute to humanizing medicine and literature, because as Edmund Pellegrino once said, medicine is the most humane of sciences, the most empiric of arts, and the most scientific of humanities. And so here, I just kind of give examples of famous artwork throughout the centuries. Okay, so the main question, how are neurosurgeons portrayed in cinema? If you recall the show Dr. Death, which I'm sure many of you are aware of, this sparked great controversy and publicity about neurosurgeons. And so we wanted to kind of investigate how they are portrayed in film, because this can influence public perceptions. And we wanted to explore what specifically are the stereotypes that have infiltrated the media. We began with a literature review. In terms of literature review, many examined neurosurgery in movies, for example, neurosurgical diseases and techniques, erroneous practices, and neurosurgeons in early cinema. However, literature lacked extensive film review of contemporary neurosurgeon personalities, sociodemographic characteristics, and interpersonal relationships. And so, instead of a systematic literature review, we performed a systematic film review using Prisma criteria. And we can see here that we looked for movies that featured a neurosurgeon using the IMDb Bestsimilar and TMDb databases with the keywords neurosurgeon, neurosurgery, brain surgeon, brain surgery, and brain transplant. We identified a total of around 500 titles. We eliminated duplicates and TV shows. We eliminated films released before the 2000s to maintain our more contemporary approach. And further titles were excluded if there was an absence of the neurosurgeon character, or if the films were inaccessible through internet search or film platforms. And so we ended up extracting data from 59 studies. There were two individual viewers, and any discrepancies were discussed with the senior author. And here are the list of the film titles and kind of what year they were released in. Okay, and so our results, you can see that our movies included a wide array of international films. However, there were a lot of international films that were inaccessible, as I mentioned earlier. And so this reflects the bias of more of a dominant Anglo-Saxon culture and database. And so this Western perception, right, decreases the generalizability of the study. However, we were able to see a variety of genres, drama, comedy, thriller, and among others, fantasy, crime, romance, etc. We also examined director, producer, and neurosurgeon character genders. As we can see, the characters have been mostly men, but surprisingly, producer gender, we see a larger proportion of females. Other factors that we looked at, age, race, and the role of the neurosurgeon. And so, for example, in terms of age, we hypothesized that a majority would be portrayed as older, given the public perception of an extensive length of training. However, we did see a lot of young adults portrayed. And there's also a favorable representation of minority groups. And role, we examined whether they were lead figurants or supporting figurants, in the sense that were they characters without lines or had very little screen time. And more importantly, we wanted to analyze their interrelationships with the patient, family, friends, hospital staff, partners. And so the trend was that they're mostly positive relationships with the patient, but there's a considerable number of movies that omitted any relationship at all with family, friends, partners, and staff. We also looked at markers for economic success. A majority of the movies did not depict these markers. Neurosurgeon education, were they imposters or someone practicing out of their area of expertise? For example, in Hannibal, although he's a psychiatrist, he performs the role of a neurosurgeon. And largely patient outcomes were that they would save the patient. And so this was also a qualitative study, and we included several quotes that we found very interesting. And I just wanted to bring to your attention, for example, the last quote that says, "What are we if we don't try to help others? We are nothing at all." This is from the movie The English Surgeon from 2009. And in conclusion, we found that many movies omit the portrayal of the ordinary day-to-day neurosurgeon that is human, leads a life with family, friends, has hobbies. There's this perception that neurosurgeons are unidimensional workaholics and not well-rounded people. And in the sense, the media omits their humanity. And this is a problem because if these are the only exposures that many people have of neurosurgeons, right, through the films, and they might stray from seeking care or trusting neurosurgeons altogether. For example, with the Dr. Death show, that painting the neurosurgeon in a very negative light. And so while in general there is a neurosurgeon character stereotype and the field remains largely male dominated, there is encouraging amount of films that do show that the stereotype is not as pervasive as we might have thought. And since the field has been diversifying, this reflects that films also tend to veer towards this inclusion. And just kind of summary statement, Dr. Sam Polofsky, a past AANS president, also commented on this very topic. He, in these words, he summarizes that although the efforts of trying to do what's best can sometimes perpetuate the very stereotypes that we see portrayed in these films. And so acknowledgements, this was a project that I led with Dr. Richardson and among other colleagues.
Thank you. That was very interesting. Next, we have Colin.
Okay, fantastic. So thank you, Dr. Landy, and thank you to the entire neurosurgery department here at Miami. I can speak for all of the sub-Is when we felt very welcomed here, and it's been a really unique and special experience for all of us. So thank you so much. So today I'll be presenting my study that evaluates scoliosis as an independent risk factor for critical illness and COVID-19 infections. This study was inspired by the incredible work done by healthcare workers around the world, particularly those in the neurosurgery field during the pandemic. Faced with an unprecedented volume of critically ill patients, institutions like Miami adapted and innovated to care for their city while simultaneously researching the disease, treatments, and publishing guidelines for hospitals around the world to care for their own communities. I highlighted here some of the impactful articles from the neurosurgery departments in the US that help shed light on the association between COVID-19 and thrombotic ischemic stroke. So for a quick background, we all know COVID is a respiratory virus that can cause significant disease in older patients and those with chronic comorbidities, such as those who are immunocompromised, have metabolic disease, and particularly those with lung disease. While vaccinations and advances in care in acute treatment have significantly reduced the risk of critical illness, many of these at-risk patients still require hospitalizations and even ICU level management. With the emergence of new strains and outbreaks, research on the risk factors for severe disease remains very important. So the goal of this study was to determine whether scoliosis, which can lead to respiratory impairment, presents as a significant risk. So a little background on scoliosis. Scoliosis is a common deformity of the spine that can range from a slight curvature to three-dimensional helical twists. While the deformity in the spine can present in all planes, it is most commonly assessed in the coronal plane, which in a healthy spine should be a near straight line. The degree of deviation from this straight line is called the Cobb angle, measuring the angle between the superior end plate and the inferior end plate of the most affected vertebrae. Scoliosis is defined as a Cobb angle greater than 10, mild scoliosis being between 10 and 25 degrees, moderate 25 and 40, and severe greater than 40 degrees. These classifications, along with functional impairment, guide our management, as the degree of scoliosis is negatively correlated with respiratory function. A study by Wang et al. In 2019, a graph is depicted in the right here, shows that Cobb angles greater than 65 to 70 degrees are often associated with significantly reduced respiratory function. It's hypothesized that these large thoracic curves alter the geometry of the thoracic cage and inhibit vital inspiratory and expiratory muscles, reducing the compliance of the chest wall and leading to restrictive lung syndromes. So in this study, we utilized a database of COVID-19 patients provided by Mount Sinai. We identified 190 patients with a positive PCR COVID test and ICD-10 codes for scoliosis. And this is from March 2020 to June 2021. Of these 190 patients, 61 patients were excluded due to age being less than 18, active pregnancy or cancer, insufficient imaging to assess their scoliosis, previous deformity correction surgery, or COVID vaccination. So this left us with a total of 129 unvaccinated COVID positive patients with mild to severe scoliosis. So in our study, we had two independent measurers confirm the Cobb angle of each subject using supine CT and X-ray images taken within a year of their COVID result. The apex and degree of the major coronal curve was used as a primary location and severity of scoliosis. The subjects were grouped into no scoliosis, less than 10 degrees, mild scoliosis 10 to 25, moderate, and severe, as shown below. Our outcomes of interest included hospitalization, ICU admission, development of acute respiratory distress syndrome, endotracheal intubation, and mortality during their hospitalization. So for our pre-infection comorbidities, we compared them using Pearson's chi-squared and ANOVA. The cohorts only differed significantly in their age, but they remain reasonably close to each other. The mean Cobb angles are also listed below, and we can see that all scoliosis apices were in the thoracic and thoracolumbar spine. We then did an unadjusted analysis and a multivariate logistic regression model controlling for age, gender, BMI, and other clinically relevant comorbidities, some that were listed in the previous table. We created this to investigate the effect of the degree of coronal scoliosis as a predictor of critical illness. As you can see, none of our analyses reached significance. There was not a significantly higher percentage of hospitalizations, ICU admissions, mechanical ventilation, or mortality in any of the cohorts. We also did not see that there's a significant trend or consistent effect of the degree of scoliosis on an increased likelihood of adverse outcome. So while this study is limited by its patient size and retrospective design, our sub-analyses showed that only 4 out of our 29 patients had Cobb angles greater than 65 degrees, which is, as I mentioned before, where we see most of our patients start to develop some of these restrictive lung diseases from their thoracic cage deformities. This could explain why we did not see a significant effect in our severe scoliosis cohort, and really will spur us to move forward and investigate these patients with these very significant degree of scoliosis. Future studies will also seek to evaluate sagittal deformity and how kyphosis can potentially affect this population as well. So the main takeaways from this study, I think, despite the negative findings, is that this analysis provides implications for the risk of any respiratory illness or community-acquired pneumonia poses to a patient living with scoliosis. While a seemingly apparent connection could be drawn between severe disease from community-acquired pneumonias and patients with respiratory compromise due to thoracic cage defects from their scoliosis, very little research actually exists on this topic. So our results suggest that these patients may not be at a significantly higher risk than the rest of the population. Prospective longitudinal studies are needed to further describe this risk, but this initial assessment can provide a degree of comfort to many patients living with scoliosis in this era where pandemics constantly resurface, and allow them to enjoy their lives a little bit more. So that's my study and my presentation. I just wanted to give a special thanks to some of my mentors, Dr. Konstantinos Margetis at Mount Sinai and Dr. Lahner at Mount Sinai as well, and the neurosurgery department that supported and funded my research. Thank you so much.
Very good. Thank you very much. And finally, we have Eris.
Okay. Hi, everyone. I'm Eris, and today I'd like to present a project I worked on most recently under the guidance of Dr. Fawaz Mufti in collaboration with the Westchester Medical Center Department of Neurosurgery. I will be discussing the topic of early tracheostomy in patients undergoing mechanical thrombectomy for acute ischemic stroke. So according to the American Heart Association, acute ischemic stroke is the 5th leading cause of death in the United States, with an incidence of 236 cases per 100,000 population. In addition to that, stroke-related healthcare costs are reported to exceed nearly $70 billion every year in the US alone. And in terms of the actual standard of care for these patients with large vessel occlusion, endovascular mechanical thrombectomy has been shown in several landmark stroke trials over the last decade to have superior outcomes for eligible patients over medical management alone. However, for stroke in general, respiratory compromise is a known common complication, which is often multifactorial due to disturbance of central rhythm generation, interruption of descending respiratory pathways leading to a reduced respiratory drive, bulbar weakness causing aspiration, and increased ICP leading to overactive sympathetic discharge and resultant neurogenic pulmonary edema. For many of these reasons, mechanical ventilation is often necessary in stroke patients to address airway failure, such as obstruction and secretion clearance, as well as to optimize gas exchange and preventing vasoconstriction and the progression of cerebral edema. Overall prognosis, however, for stroke patients requiring mechanical ventilation is poor, with mortality ranging between 40 and 80%. Thus, the optimization of airway management is especially crucial for improving outcomes in these critical patients. As a result, these patients on prolonged mechanical ventilation often require tracheostomy, and this is to really facilitate weaning as well as long-term airway protection through mechanisms including the benefits of a short tracheal cannula compared to an OT tube, leading to less airway dead space and reduced work of breathing, as well as the avoidance of oropharyngeal and laryngeal lesions, leading to improved patient comfort. And in addition to these benefits, studies have also found a reduced need for analgesia as well as sedation among tracheostomy patients with earlier mobilization and transfer to rehabilitation. However, the complications to be aware of, as with any procedure, there is potential risk for damage to nearby organs, bleeding, infection, and pneumothorax, which are all known but less common complications that may result from tracheostomy. Despite these risks, it is widely agreed upon that tracheostomy should be performed as soon as the need becomes obvious, but how this need is determined remains controversial, and the optimal timing of the procedure is still unclear. In current clinical practice, the procedure is commonly performed 1 or 2 weeks after intubation, and this often occurs after extubation attempts have already failed. Specifically, for some reference of a national average, in one retrospective database study by Chatterjee et al., they reported an average post-stroke timing for tracheostomy of 10.3 days after mechanical ventilation. So now with this controversy of timing in mind, our current project builds upon prior RCTs, most notable of which being the SET.1 trial in 2013 and SET.2 in 2022. SET.1 was a study out of the University of Heidelberg in Germany, where post-stroke patients who were estimated to be on prolonged mechanical ventilation for at least 2 weeks were randomized to either early tracheostomy, which was less than 4 days from intubation, or to the standard timing group, which was between 7 and 14 days. So although in this study, ICU length of stay was not significantly different between the two groups, they did find that the use of sedation, duration of mechanical ventilation, and 6-month mortality were significantly lower in early tracheostomy group. Now, similarly in SET.2 in 2022, which has now expanded as a multi-center RCT in both Germany and the United States, stroke patients expected to be on prolonged mechanical ventilation received early tracheostomy less than or equal to 5 days from intubation. This study, however, now showed no significant difference in their primary outcome measure, which was functional improvement as measured by the modified Rankin score at 6 months. And additionally, this time, there was also no difference in mortality between the two groups, as compared to SET.1, which did show a positive benefit for the early group. So in both of these study samples, we see a mixed or even minimal benefit for early intervention. However, it is important to note that there was also no evidence of inferiority compared to standard timing here. So given these findings, in our current study, we utilized a highly validated National Inpatient Sample, or NIS for short, to further assess the impact of tracheostomy timing on acute ischemic stroke outcomes in a large real-world sample. For some additional context of the NIS as a data source, it is the largest all-payer healthcare database in the United States, representing 20% of all inpatient admissions every single year. In terms of our patient selection, we utilized the NIS from 2016 to 2019, which was queried first for patients with acute ischemic stroke using ICD-10 diagnostic codes. From this acute ischemic stroke population, we then used ICD-10 procedural codes to first select for patients who also underwent mechanical thrombectomy, and then in this population subset of acute ischemic stroke mechanical thrombectomy patients, we likewise identified patients who also underwent tracheostomy. And then with regard to how we defined our data characteristics for analysis, we chose an early tracheostomy cutoff placed before the 8th day of hospitalization, which in our case was less than or equal to the 25th percentile in our selected patient population. Furthermore, routine discharge was a variable we defined as discharge to home or self-care. And then finally, in terms of our outcome measures, our primary outcomes were inpatient death, complications, and length of stay, while our secondary outcomes included discharge disposition as well as total hospital charges. And now, in terms of our results, from 2016 to 2019, 132,210 patients with acute ischemic stroke were who underwent mechanical thrombectomy were identified from the NIS. Of these patients, 3,580 underwent tracheostomy. Then of these tracheostomy patients, 915 had received their procedure before day 8 of hospital stay. Looking more at the baseline demographics and comorbidities of this population, we found that among acute ischemic stroke patients who received mechanical thrombectomy, those who underwent tracheostomy were more likely to be younger, have greater comorbidities, a greater stroke severity score, and also more likely to have had a posterior circulation stroke. And now of the acute ischemic stroke mechanical thrombectomy patients who had undergone tracheostomy already during their hospital stay, early tracheostomy was associated with a shorter total length of stay, fewer total hospital charges, and lower rates of complications such as sepsis, DVT, AKI, and pneumonia. And finally, in a multivariable logistic regression controlling for factors of stroke severity score, age, female gender, and comorbidities, we found that patients who received early tracheostomy were independently associated with reduced rates of prolonged length of stay greater than 21 days and reduced rates of prolonged mechanical ventilation of greater than 96 hours, as well as reduced complications of pneumonia, sepsis, and acute kidney injury. So in conclusion, we found that early tracheostomy was associated with reduced total hospital charges, decreased length of stay, reduced length of mechanical ventilation, and reduced rates of pneumonia, sepsis, and AKI. Our findings add to the current body of literature illustrating the benefits of early tracheostomy using a nationally representative sample of acute ischemic stroke patients. And these results really suggest that early tracheostomy may further play a role in facilitating discharge and recovery. Now, we believe that further prospective validation of these retrospective database findings, as well as study of placement and timing of tracheostomy, is warranted to really better optimize post-stroke patient outcomes, which often unfortunately includes respiratory compromise. As for the limitations of this study inherent to any retrospective database research, we have limited availability of outcome measures, such as the modified Rankin score, which is not possible to calculate within the NIS, unfortunately, even though it is a useful tool to study post-stroke functional outcomes and compare to past studies. Similarly, with a non-randomized retrospective database analysis, all of our patient information is extracted using ICD-10 codes, which can be heterogeneous throughout the nation, with an inherent risk for incorrect coding. Although we did seek to mitigate any errors due to the shift from ICD-9 to ICD-10 coding by focusing on the years 2016 to 2019 only. And then furthermore, in terms of limitations, the NIS only captures the duration of the hospital stay and lacks long-term outcome data. And finally, clinicians' occupations, practice patterns, and clinical experience is not always available for evaluation, which may have an effect to introduce bias to our findings. So although several of these limitations exist, our large cohort size and utilization of national data very much highlights the broad applicability of our findings as compared to smaller trials conducted in the past. And to the best of our knowledge, this study represents the first evaluation of tracheostomy timing in acute ischemic stroke mechanical thrombectomy patients on a national scale. These are our references, and happy to share that this study was recently published as of 3 months ago to the Journal of Critical Care. Thank you very much for listening to my presentation, and again for the opportunity to rotate here at the University of Miami. I really had a great time and honestly could not have asked for a better experience than I've had this month. Thank you again.
Great. Thank you very much. Thank you to all the presenters. Very nice studies, all of them. That will conclude today's grand rounds. Thank you.